starting the recording now. So let's get going. One area that I wanted to cover is some assessment considerations from last time that got raised from our previous webinar, and issues to consider with youth during assessment. And I think one of the big areas when we are talking with youth from a developmental framework is being mindful around the social, cultural context of substance use and how substance use is embedded within our culture, within music, within film, within neighborhoods. And because of that, we need to, as providers and clinicians and systems, we need to be sensitive to language and terms around substance use, particularly among youth who tend to have pro-social attitudes and views about substance use, either seeing it in the home, seeing it in the neighborhood, you know, with access and availability with some of the usual suspects around alcohol, now marijuana, tobacco. We need to be very mindful of that culture, and so one way to be mindful is using terms and language that aren't clinical or that could be stigmatizing to youth. Some of the work I've done with youth in treatment settings is that they don't like to be told that they have a clinical problem, that they need treatment, that they have a disease, and there's a lot of stigma and shame around that. You know, the notion of lifelong recovery. These are the terms on the right-hand side of the box. You know, entering a drug program, a rehab, total abstinence and sobriety. These are adult terms. We've used them and we've developed them through research around a sick model, around what we see from adults in treatment programs. And what has occurred is youth systems tend to adapt and use these terms as well as appropriate as terms that fit an adolescent model, and they really don't. Some, you know, more times than not, there needs to be some nuance or some discussion around that these terms are used in the field around substance use disorders and addiction, but largely come from the adult model. And so from a youth perspective, I think they're important to be used as educational kind of factors around exposing youth to the realities of addiction in the long term, right? And really talking to youth around risk and how they are a population where if they continue to use with their patterns like we talked about last time, it sets them up for risk of having lifelong recovery, of having a chronic disease, of the need to be in a total abstinence kind of setting or model. So the words on the left are more developmentally appropriate, and we need to think about these as we do our assessments, as we do our screeners, and as we do our treatment or our therapeutic services. And so I kind of compare and contrast terms of what the one on the right would go with more developmentally appropriate. So services, use services instead of treatment. Instead of rehab or drug program, maybe call it a center, a wellness center, a leadership institute, an after-school program. Instead of chronic disease, just call it what it is. It's substance use behavior. In views of adolescence, it's a behavior. It's not a disease. It's not an illness. Instead of relapse, call it continued use of their behavior. Lifelong recovery, they're more focused on lifestyle change. Sobriety, the word wellness seems to be less stigmatizing. And then instead of abstinence, behavioral self-management would be more appropriate. So just to be mindful of the terms that we use, the Surgeon General's report that got put out in January talks a little bit about this. It doesn't go into great detail. You're not going to find this compare and contrast list, but this is one that through my work in the field of development and working with youth seems to be more appropriate and more fitting. You might use different words as you know, as you begin to work with, as you work with youth, you know, think about what would be a more appropriate word or language. Okay, so I wanted to bring that up. Also, during assessment, another developmental consideration would be the inclusion of parents. And there's a couple of considerations that need to be thought through. This could become a sticky issue in certain settings, and there's a lot of individual differences where the family unit and how family is operationalized. And so I encourage, depending on your youth and what types of youth you're working with, where they're high risk or at-risk youth with a lot of trauma and a lot of family dysfunction, or they're come from an intact family with, you know, some dysfunction but not as much as other youth, I would encourage just use of a, you know, support system. What does your support system look like? Sometimes the word family can be a little stingy with certain youth. So, you know, being sensitive to that, being mindful of that language, and so I encourage just the use of what does your support system look like, and inclusion of a support kind of person involvement. We say parental involvement broadly, but I would encourage you to operationalize that in a broader way during assessment, and how to integrate a support system within services and treatment planning. And so whatever that support system would look like for you, that agent or that person, during assessment, I think it's critical to include them in the assessment process, to include them because we know that youth substance use doesn't occur in isolation or in a vacuum. We do know that a large issue, like we talked about last time, in terms of risk factors, is the social environment defined broadly, which includes neighborhood, which includes school, and which includes this kind of family or social structure unit. And so including the social structure or support structure within the planning and assessment and also the delivery of services is critical. We'll talk about that more in a little bit. But when you begin to consider including, you know, parental involvement, quote unquote, in the assessment process, I think it's important to think about how you're going to do the assessment. Is it going to be a joint assessment, or is it going to be individual? I think what's a best practice is an individual assessment at first, which is important just because of the conflict that might be occurring with shame, with conflict around the substance use and the support system with the youth. So I think being mindful of that, one step would be to have separate assessment practices. So what of the ASAM assessment that you want to collect information from parents or support system would be dimensions 2, 3, 5, and 6 in particular. 2 is around Dimension 1, no, I didn't include here. Dimension 1, if you recall, it's all about their substance use and their substance use history. When you begin to ask parents or support systems, what does your kid use? How often do they use? Who do they don't know. You know, they want to know, but they don't know. So asking them those kinds of questions will just probably create a lot of anxiety for the parent around the nuances of that. So what they tend to know more about is their behaviors and their issues. So Dimension 2 is around their health issues and health concerns. Dimension 3 is around their mental health and cognitive and behavioral issues. Dimension 5 is around their continued potential for relapse and, you know, peer issues. And then number 6 is their actual home environment, right, their recovery environment, their school. So parents can speak into this, I think, in ways that would be useful, that would add to whatever youth give you. And notice I didn't put Dimension 4 in here. That's readiness for the youth to be engaged in treatment. And so, again, parents, they might be able to speak into readiness, but that's going to really come from the youth and their own perspective and their own desire for engaging in treatment and not being forced to. So I just wanted to point that out. And then being including the support system during assessment is critical, and having them fill out their own assessment, because then it engages them and it creates responsibility that they're part of this. And you might have a separate section within, or maybe it's even these sections around dimensions, these dimensions where certain case management around health and social needs might arise, where then the parent can also be an advocate or involved in the case management of their youth, of like, here's what they're going to need to be taken to. Maybe they need to be plugged back into school, or maybe they need to be taken to health care or mental health. And so getting the parent or the support system alerted to that early on versus just saying the youth, well, okay, we're going to have a treatment plan with you, youth, and here's your case management. Developmentally, we know that youth need hand-holding. And so using the parent as that agent to really reassure that they are following through with case management and those types of resources is important, and that can be done through that assessment process. It's also a time to engage parents and give them educational material that they might need around substance use, and it being risk versus disorder, and really nuancing, giving them information up front around what material of maybe the mission of the program and the agency around prevention, around tips around how to begin to deal with your youth, what to know, the do's and don'ts, right? Because they're in a state of anxiety. They're also really nervous. They don't have any resources. They're probably going to be looking to the program for resources. So I encourage agencies to develop a family resource list and, plug them into, SAMHSA resources and links, and have them do their homework, right? Plug them into the Office of National Drug Control Policy. Plug them into these NIDA websites up front and say, here's what you can begin to look into around alcohol and drugs and around resources for you, right? And so give them some material that they can engage with on their own. And then, of course, set the stage for the family services that they're going to be participating in. So I think it's critical to include family during assessment given these issues. A note on service eligibility and limitations for youth, the youth system of care. There are some nuances, and I know Shasta County is participating in the DMC ODS waiver, and with that, the benefit of EPSDT kicks in, right? And what is that? That's a federal and state assurance for youth under the age of 21, so youth minors, we call minors, remember we talked about definitions last time, from 12 to 20 would be youth beneficiaries, those who meet medical necessity are eligible. What does that mean? They have access to the full scope of Medi-Cal under EPSDT. This is different from the general drug Medi-Cal without the waiver benefit, right? And so these are the services like, individual counseling and recovery support and continued assessment should they meet medical necessity. Their services aren't capped, right? They're not, and even family inclusion or whatever services meet their needs, they're covered within an EPSDT framework as needed versus the Medi-Cal minor consent program. That program has been available in California, but under 2011 Realignment Fund, this program is now supported 100% at the county level for youth under 21. So youth have the ability to consent under the family law in California. Should they do so, costs of services are going to be left to the county. And so should they opt into this program, the EPSDT benefit does not apply, right? So there's something to be mindful of. So like services are under ODS DMC, like individual counseling, case management, recovery support are not covered. So youth who want regular full scope Medi-Cal are required to have their parents apply on their behalf. So there's just some nuances there, and I thought I'd cover this because in LA County there's a lot of programs that use this Medi-Cal minor consent program because, kids don't want their parents involved. We know from a practice standpoint that's already puts the system and the youth at a disservice, and really trying to break through barriers and get youth to understand the importance of that is probably a best practice versus, we can get you to, there's this program available where you can sign a waiver. However, we do recognize that there are instances where this is a good program around safety and issues of some sort where their youth are on their own. So I think it would be a clinical judgment call, but just understand that the EPSDT benefit, it does not, would be void if this program is used. Okay, so how to effectively address youth who meet medical necessity for at-risk? So let's spend some time talking about at-risk for developing substance use disorders versus youth who meet medical necessity for an SUD and then would require therapeutic treatment services, if you will. So SUD risk is addressed by risk reduction approaches, right? We want to reduce risk. This is not treatment. Youth who meet medical necessity for having at-risk should not be given treatment because they are not at that clinical threshold yet to need treatment. And in the past, youth that come into our program have, we haven't really distinguished at-risk versus having a substance use disorder. So all youth have been given the same thing. They've been given treatment, quote unquote, right, because of the mandate. And for our system, this has been an issue because we're either over-medicalizing them, and what does this do to youth? We talk about youth are resistant, youth are combative, youth don't want services, they're in denial, but we need to recognize that they may not have needed the full-blown scope of treatment, right? And so this is an opportunity for us as a system to really be sensitive to their needs around SUD services. And so this allows some flexibility around giving them some services, right, don't call it treatment, but services around intervention services that can still address the SUD risk. So they're called risk reduction, they're called early intervention, sometimes they're called behavioral intervention, motivational intervention, risk reduction, and a brief intervention, borrowing from SBIRT, screening, brief intervention, referral to treatment. That brief intervention is a risk reduction, right? But it's just in certain settings, like in medical and mental health, the brief intervention is done really quickly, one snapshot in time. So I think it's important to think about settings. So if you're in a school setting and your youth are in a school setting, a brief intervention maybe one point in time would be feasible, but it would need probably a follow-up session, right? So 2 sessions. So Ken Winters developed the Teen Intervene. That is a risk reduction model. It's under SAMHSA's NREP Registry of Evidence-Based Practices, where the intervention or the brief intervention occurred over 4 sessions, about 30-minute sessions. So I think it's important as a system begin to identify what does an early intervention or a brief intervention or a risk reduction intervention look like is going to be nuanced to meet the needs of the county and resources. But I think what we know from the literature is that, at least from best practices, a brief intervention in substance use settings should at least be a maximum of 4 and a minimum of 2 around parameters. So it is really, the intervention is targeting what? It's targeting their risk that was identified in the assessment, right, in the ASAM assessment or the risk determination. And so what's targeted? Behavior change, right? They don't have a disorder, so you're not going to kind of work towards a treatment plan that's going to get them into treatment goals around abstinence, and these types of things don't work with these youth, right? It's really around reducing their risk behaviors and really honing in on some of the issues that were identified in the assessment around risk, or what were those risk factors were. And so the desired outcomes, like I mentioned earlier, is not abstinence, right? When you begin to implement risk reduction interventions, they target different indicators or risk indicators. And they're in the boxes above. These are the larger kind of theoretical outcomes that are targeted in risk reduction interventions in general. These are awareness of risk. More times than not, youth don't understand their risk. So it's during the brief intervention service, it's opportunities for the counselors to educate them and inform them about their risk, right? These youth also, we learn from research that they don't really have maybe confidence or self-efficacy to change because of their peer culture, because of their social surrounds. They feel like they might be rejected, or they might not fit in anymore into their peer group. So this self-efficacy, or their confidence in their ability to withstand pressures to use alcohol and drugs is an issue. So one of the targets would be their self-efficacy or their confidence around changing their substance use. Another outcome or important risk indicator is attitudes of risk, right? We talked last time about perceptions of risk, where youth don't think they're at risk. They have biased perceptions of risk around this having a disease or having a disorder. And so that's another area to target during a brief intervention or risk reduction intervention. And one of the bread and butters of brief interventions or risk reduction interventions is targeting motivation. So this is a critical ingredient, right? Their own desire to change. And this is really going to get at purpose, right, and values. Why are they using alcohol and drugs? What is the purpose? What is it doing for them? This is their values, their attitudes. This is going to affect their motivation. So awareness, confidence, and attitudes all influence motivation, and then motivation is going to influence their intention or their actual changing their behavior. We learned this from models of theory of planned behavior and theory of reason action. We learned this from social cognitive theory, all around theories around behavior change. These are important indicators, and these are well supported by research. So during a brief intervention, the goal of the intervention services, given these indicators, would be not to immediately change their behavior, right, moving them from like whatever state they're in to behavior change. It's a process, right, and we know that behavior change occurs in stages. We learned this from trans-theoretical model or stages of change. So the underpinning of risk reduction interventions is approaching youth using a stages of change model, right, moving at-risk youth along these stages. So I really identifying where they're at with change, and on dimension 4 of the assessment, you're going to get at that, right? You're going to get, are they pre-contemplative, are they contemplative, you know, maybe they need preparation, maybe they know they need some skills perhaps, or some resources, whatever it might be, to get them into stage 4, right? But the goal of a brief intervention isn't to end in behavior change, right? That's why it might take a series of sessions. The goal of the risk reduction intervention is to move somebody, let's say, from stage 1 to stage 2. That's a win in one session, right? Or moving somebody from stage 2 to 3. That's also a win when you're dealing with youth who are at risk. And then ultimately moving somebody from stage 3 to stage 4, right? So from doing risk reduction interventions, just like treatment, the goal is really a behavior change process and getting them to work through stages of change. And so how do we do that? Well, motivational interviewing, right? So one of the other aspects of risk reduction interventions is using a stages of change model, but also using motivational enhancement strategies to really target that motivation to change, the intrinsic desire, right? Not you telling youth that they need to change because it's bad, but getting youth on their own to take responsibility, to understand that they're at risk, right? To change their attitudes, their biased attitudes about risk, to help with their confidence, and ultimately impact their desire or their motivation, right? So the bubbles I showed earlier all really work together. And in the research, we've learned through systematic review and meta-analysis through Smith and Lipsey, and we have a lot of work that's being done that continue to look at the impact and the effectiveness of brief interventions or risk reduction interventions. They are very effective for youth. And they're defined as a series. This is the definition that NIDA uses, National Institute of Drug Abuse. They're defined as a series of brief sessions, not just one, within a context of alcohol and drugs, right? A series of sessions between a provider and a youth to discuss risk, right? And explore reasons or plans to change. So this is really the nuts and bolts of an intervention, really targeting risk. So motivational interviewing, there's really two critical ingredients around effectiveness that these meta-analyses have shown. One is the style of communication, and the other is facilitating change talk, right? The key is getting youth to move away from sustained talk, right? Talking about, well, alcohol, I have no problem. Alcohol and drugs, they fit into my life, and you know, it's my parents who have a problem, and it's, you know, you who are telling me you have a problem. But it's getting them on their own to identify change and the need for change. And so how do we facilitate change talk? Well, one part of it is building a relationship first, right? So, and meeting them where they're at in terms of their stage of change. So motivational interviewing is designed to enhance the youth's own intrinsic motivation and, through these series of sessions, commitment to change within an atmosphere of what? Acceptance and compassion, meeting them where they're at. And it's inherently patient-centered. Risk reduction interventions are not group settings. They're individual-based counseling sessions, right? They're one-on-one. They're patient-centered because they are looking at the unique needs, the unique risks of that adolescent or that youth, right? We talked about individual differences. And so another way interventions are effective is that it is really honing in on the unique risk of youth. When you move into clinical models, there's clinical practices in which youth would benefit from collectively because they are maybe all dealing with craving, or they're all dealing with not really being able to control relapse or whatever it might be. But with youth who are at risk, they have a lot of different risk factors and nuances, and so the benefits and the utility is really honing in on this patient-centeredness, focusing in on their individual reasons that are valued by them versus us from a clinical perspective, right? The writing reflex, like, I know what's good for you because. So that's a key component. The style of communication is effective, right? The MI style of communication, the motivational interviewing style, is effective with engaging youth. Why? Well, if you look on the left, a key issue with youth during the developmental period, right, we talked about last time, is that their brain isn't fully mature, and one of the last parts of their brain to fully develop is, you know, this cognitive part that deals with decision-making and impulse control, and there's a lot of social-emotional development and changes, right, identity formation. One critical aspect of development and youth is autonomy, and them really being individual and them being control of them and their lives, right, not being told what to do. This is a critical developmental area that I think is important for us to recognize as providers, and where MI is very effective at, and really helping engage youth and giving them autonomy, respecting where they're at with their behavior, showing compassion, empathy, providers taking on a supportive role versus a teacher or lecturer role or a clinical role, showing them non-judgment, you know, should they say they're using and they like use, and being acceptance, right? Versus a directive confrontational communication style that's like, well, you know, you need to stop what you're doing, it's gotten you into trouble, and, you know, using the legal channel or authoritative channel is not effective in the beginning, where you don't have any rapport built. You don't have, there's walls that are up. You know, we do know that we need to engage them in a way, foremost, where we develop rapport, where we develop alliance, and so using that direct style initially leads to disengagement, and we know that engagement is a critical piece with youth. The chart here shows you, they can be angry, they can be feel ashamed, they can feel not heard, uncomfortable, frustrated, annoyed, on and on and on. So this style and stance during this brief intervention sessions is critical. I talked about autonomy. Here is just kind of reiterating that. Autonomy is this critical element of the developmental period where youth establish their own uniqueness, their values, their goals, their interests in self-governing, making their own decisions without depending on others. So understanding this developmental process is important with respect to really understanding the importance of them being independent and this notion of autonomy, and really showing that, like, this is your service. Like, we're not here to lecture you or judge you, but we're here to simply see how we can be helpful with your risk issues. Talking about youth have biased perceptions of risk. On the right-hand side is an article that I published a few years back, but it really talks about this nuance of perceptions and youth perceptions about what they need, what they think, right? And really kind of digging into this area around perceptions is critical. When we get into healthcare, we always ask, are you the patients? Are you comfortable? Are these services appropriate? Did you like the services? Are these meeting your needs? Right? When we get into substance use system, we don't do that. We don't spend enough time asking youth, or adults for that matter, do they feel comfortable? Do they feel like these services are needed? Do they feel that, what is their need? And now moving towards ASAM assessment, I think it allows some flexibility around, Dimension 4 in particular, around client readiness. That's really a space to get at client need, client perception. What do they need? How do they view their behavior? How do they view their use, and what types of services might work for them? There's a lot of research on this element of choice, particularly with youth, being very effective, giving them options versus telling them this is what you need, right? We have a menu of options and services, and, what might be something that would fit for you and where you're at. This is done in healthcare. We have medications, we have, these services or these services. We don't do that enough in our system with our clients. And so really honing in on their perceptions and their perceptions about treatment and their needs, have really identified that youth, majority do not believe that substances are harmful to them or addictive for that matter. This issue around marijuana that we now have, the graph on the bottom really depicts that. And if you look at the chart, there's an inverse correlation. What does that mean? As perceived risk, or their attitudes about how harmful or addictive or risky, if you will, marijuana is directly correlated with their behavior, their use, right? So orange is their attitudes and blue is their behavior, and it's inversely correlated, right? As one goes down, as their perceived risk or attitudes about harm go down, their behavior, the blue, goes up, right? And so this is an issue. This is an issue for that interventions and risk reduction interventions can capitalize in on, right? And really exploring and discussing risk and the nature of risk from the addiction model that we talked about last time, really using that information about the brain, about patterns with youth during these sessions to educate them, I think is a critical piece that might be missing, because in treatment, it's usually there's psychoeducation perhaps, but this critical, and they're already focused on you have a disease and let's undo it. I think interventions are opportunities to focus in on, let's look at the risk. Let's look at that trajectory. Let's look at the nature of your use and what it's going to do to you, perhaps in the long term. And this is important for youth because many view substance use as this behavior, not an illness or disease like I talked about earlier, that can be changed through what? Personal control. their own way of doing it. And we need to explore during an intervention, what does that look like? What does change look like for them? And using MI and using strategies around change, I think, can be critical because they do parallel and map onto youth perceptions of risk and how they view substance use. Okay, so the MI strategies that help with evoking change and what change might look like for them, there's strategies and there's principles of MI. I'm going to cover some strategies first, and this is just high level. When we get into maybe next steps of maybe an in-person training around MI and case studies around youth, that's where we can kind of dig into and allow you to get practice around this. But this is just giving you an overview of big picture of what a risk reduction intervention would use. So you would use MI strategies around, they're called ORS. Many of you are probably familiar with this, but ORS is an acronym, and it stands for, like the communication stance, but it gives you, it pushes you a step further in terms of how you have the conversation, right? And they really emphasize open-ended questions and really listening, right? So these are two key ingredients, the O and the R. And then as you listen, the A comes in, where you affirm. You don't disagree, you don't argue, you don't say, yeah, you think that, but. There's no buts. It's like you affirm, you acknowledge where they're at in terms of the stages of change, right? And then at the end of that conversation, you engage in the S. You provide a summary. Here's what I heard you say, right? Is there anything else? So you are simply listening to them. And this breaks down walls. This helps develop engage youth, and it helps also evoke change language, where you're going to be asking them open-endedly about their session. So on the right-hand side, open-ended questions, you encourage a collaborative discussion, and silence is useful. You know, this is going to be something that is going to take practice and adjusting even with the clinician or the provider, because silence usually is like, uh-oh, I got to fill in the space here because we need to talk about something. But youth, and then with youth, they're not used to being asked what they think or how they feel. They're used to being told, like, why did you do that? Don't do that. Do this differently. Here's what you should be doing, right, from their parents or from the system. So shifting the service around a model around collaborative discussion about, okay, tell me more about what you want to get out of this session. They're going to be like, what? You're not going to tell me what to do? Describe how use fits into your life. Oh, well, I like it because, and then you affirm and you recognize that. You at no point in time tell them, oh, well, that's absurd, and you think that now, but, it's bad for you. What will happen if you stop using? How will it affect your life? So you open-endedly explore what their use looks like for them and what they want to get out of the service. You explore their perceptions. And then you affirm them. You express positive appreciation, because talking about alcohol and drug use is not comfortable. It doesn't come easy for youth. They're scared that they're going to get in trouble. They're scared that, they're going to be viewed differently. And so thank them for their honesty. Thank them for sharing. Tell them, acknowledge that it's tough to talk about it. So that's a space that you can express that. Reflective listening is you tell them up front, like, I'm a learner. I'm not here to tell you what to do. I'm here to just learn about you and how use looks like for you and what change might look like, what change makes sense for you. And then provide summaries. Restate in their own words without interpretation, right, what they said. And then also it's critical to ask, is there anything else they would like to add before, moving on? This is kind of critical to get them to evoke in a change process, right? Getting them to really have some engagement and have some rapport, and then you adopting a role and upfront telling them, I'm not here to tell you what to do, and this is all about you. They're going to be engaged actively in a process of what? Responsibility, autonomy for their own improvement, for their own change. And so these are critical strategies during a brief intervention. Youth resistance is common. Another piece that I published is around this area about perceptions of their recovery needs and how to avoid drug substances in their community. This is where self-efficacy is really critical. If you look at the bottom, perceptions around recovery needs, young people, it isn't really about the drugs and the negative impact drugs are doing on their lives. It's really about what the purpose and function that substance use is doing, right? So emotions, right? It helps them fit in. It helps with their self-esteem. Stressors. A huge issue among young people is stress, school stress, parent stress, sports stress, peer stress, relationship stress. Their self-efficacy to be in a setting or their confidence around, all their friends are doing it, if they're involved in groups or relationships, right, and not feeling like they're not going to fit in or they're going to be the loser or whatever term they use. Their social culture, right, their neighborhoods, and it just be constantly around. And so their resistance to us is seen as clinical, like, well, we know what's best for them, but we need to understand the realities of what their life is consumed with. And it's stress, it's their social culture, it's their emotions, it's their self-confidence, and then it's their lack of support system, right? Their parents don't trust them, or maybe they're done with them. They're lying, and like it's now the treatment program's responsibility to fix them, right? And it's like, whoa, here. And they don't have, maybe they're not engaged in recreational activities, maybe they're not engaged in wellness activities, right? They don't have a solid support system. So we're up against this current, and so when we begin to engage in interventions, it's important to recognize that their resistance isn't coming from them being just resistant and then wanting to engage in illegal anarchy. It's really tied to a range of areas that I think we need to be sensitive to and we need to acknowledge and talk to youth about. So shift away from a righting reflex to a supportive role, the goal of immediate action to a stages of change given these nuances, and then expert provider to learner, right? What are the youth perspectives? What can we learn from them? And then how does youth fit into their life and current needs, I think is very important given this issue or these issues. And which speak to the next kind of strategies around MI that are critical, which are these on your right-hand side. So the other importance of risk reductions, or the other critical kind of area that is effective with youth who are resistant or who struggle with change because of these nuances, is these MI principles, right? Just expressing empathy, showing warmth, communicating support, rolling with resistance, right? Avoiding arguments, like letting them be resistant and rolling with it, and really tapping into that resistance. Why is there resistance? Is it because of those areas that I just covered, and really allowing them to see or break through some of that in a way that's effective during an intervention. And so shift focus here under roll with resistance on the right-hand side. Sounds like you're not concerned with your youth. Can you tell me about areas of your life that are stressful or bring you concern, right? And typically those are related to the youth issue. But asking them directly about their youth and the need for change is not going to get you anywhere. Then maybe come at it from the backside angle about shifting focus is important here. And then supporting their self-efficacy, right? This is critical with youth. Explore their support resources for change, but also explore their barriers for making change. What are the barriers, right? And really getting into that nuance. So during an intervention, and I'll show you the steps that you covered during a brief intervention, is negotiating a plan for change and really tapping into what does change look like for them, but do they have enough confidence or resources to make that change? So MI strategies around supporting self-efficacy is key, and then exploring discrepancy, right? So these risk perception attitudes might be really heavy, right? Like, marijuana, it's a medicine, it's not harmful, you don't know what you're talking about, right? So a way to kind of shift around that using MI is exploring discrepancy with their life values and goals, right, around, and really tapping into that. So under explore discrepancy, really honing in on how they envision their life in 5 years, right? Youth are not futuristic thinkers, right? It's all about right now, today, and that's it. So getting them to explore right now, today, versus like your future and how youth might conflict with that is kind of key here with you. So how do you envision your life to be in 5 years or later, or 10 years? How does your current behavior now affect you achieving your future plan? So this is a critical strategy under MI to use with youth who just, you know, they're not resistant, or they might be resistant, but it might be their attitudes and their risk attitudes, right, around that. So really exploring that or using that strategy would be key for those youth. Empathy, empathy, empathy. I can't stress empathy enough. Research really strongly supports empathy as being one of the best predictors, if it's not the single best predictor, of a higher success rate in counseling settings, such that counselors who show high levels of empathy or empathic skill have youth who are at risk tend to be less resistant, more likely to stay engaged in the services, more likely to change or be receptive to change, and less likely to continue to use or relapse. And so the chart on the right here shows that this is those youth who were in treatment settings. So MI, it's critical with risk reduction interventions, but it's also critical during treatment for those youth who have SUD problems, because you're going to run up against currents of the same kind of issues we're talking about. So being mindful of that. However, the slide down, the graph on the bottom really shows the value of empathy on long-term outcomes. So here it shows red shows clients that had counselors who were showed high levels of empathy had a major impact on their recovery. It shows here that they were less likely to relapse over time. What does that tell us? That tells us that youth that were in treatment settings, who had counselors who showed them empathy, who met them where they were at, who showed compassion and support, they learned stuff. They were receptive to being like, okay, maybe using skills, maybe being receptive to change and continuing that change once they left treatment. This shows that versus youth who had less empathetic counselors, right? They didn't really pour into them. They were just really telling them, giving them that, riding reflex. They tended to kind of meet the status quo of relapse post-treatment that we see, right? So there's value in empathy with youth, particularly with breaking down those barriers of, like, no one listens to me anyway, so I'm not going to listen to anyone here, right, versus listening to them, showing them empathy, and it really can do a bit of wonder. So the top here, this is just a statement that kind of fits with empathy during brief intervention sessions, is reminding them that their time today, or our time today, may be different than with other people who have talked to you, right? Other systems, legal, teachers, parents. I am not here to tell you what to change or how to change, but rather to find out what is going on in your life, how your substance use fits in, and how to help you make the changes that you decide to make, right? And this using MI, language and conversation and rapport and listening and empathy are critical ingredients for being effective at reducing substance use behaviors. So this is a brief intervention or a risk reduction intervention that we will cover in the future. Around here are the steps that you would take to engage in that conversation during those sessions. Again, tailored to the individual youth needs, because there's going to be a lot of individual differences, and what allows you to do that is using the assessment, right? Getting them to understand steps 1 and 2 are getting them to understand their personal risk around substance use disorders and that trajectory, right? Raising that subject of risk and providing feedback personalized of how their behaviors and their risk factors are putting them at risk for that trajectory. Steps 3 and 4 are getting them to identify their personal need, right, their intrinsic reasons and desires for change. So that's enhancing motivation, maybe dealing with self-confidence and self-efficacy, getting at the purpose and the meaning and the reasons, and then negotiating a plan or support structure. So these are the steps of a risk reduction intervention or brief intervention, all the while MI strategies and that communication stance are being used, right? So they kind of go, they're hinged, they go together. Really quickly, this is step 1. You would raise a subject during an intervention session. It's important to introduce the notion of SUD risk versus a full-blown disorder, and provide education on what? The drug effects, right, that we talked about last time, especially on the developing brain, taking time to really hone in on that. And then the risk factors that were identified in their assessment that research has shown set the stage for those trajectories, and really personalize it instead of talking to them generally of like drugs are bad and they harm your brain, but then in step 2 really honing in on being able to hone in on their risk factors, which is not really in step 1, but step 1 and 2 go together because it would be then personalizing it, right? Providing them feedback on, since there's research shows here's the risk factors, you have 2 or 3 of these, right? Pulling out those personal risk factors that were found on the assessment and elicit reaction, right? Ask you from your perspective, what do you think about this? What do you think about your risk? What relationship might there be between your use and this dimension factor or risk factor? Or what are your concerns about your use and this risk factor? And really, on both of these slides, if you notice, or both of these steps, the yellow, the importance of the MI skills, right? Open-ended questions, reflective listening, summary statements, affirmations, and then EDRS stands for the empathy, exploring discrepancy, rolling with resistance, and then supporting self-efficacy. So these are places where you're going to be mindful of that. And then step 3 and 4 is all around this intrinsic evoking change talk, if you will, right? So during intervention session, it's important to engage youth in motivational enhancement exercises to evoke change talk. 2 of the most commonly used ones is decisional balance exercise that really allows you and the youth to explore their values around use, right, pros and cons, and their values for change, right, reasons that make sense to them and not change. And then the readiness to change, right, what does that look like for them? And are they ready along the stages of change? And then step 4 is helping youth develop a plan of action that makes sense for them. It best meets their individual needs. So here's some kind of areas that usually fall under that. You summarize what you've learned in step 3 around their pros and cons and their reasons to change and readiness, and then you elicit change talk, right? You ask them, well, what does change look like for you over this next week, over this next 2 weeks, right, before your next intervention session. Ask them to list specific steps they make to start the change. You offer resources around change or addressing risk if requested, or if you kind of feel like you might need to lend them. And then you schedule the follow-up for your next intervention session to discuss their change status and ongoing needs. So that would be a brief intervention or a risk reduction intervention, high level. The importance of case management services, right? So under the waiver, if should youth meet medical necessity, they should be given a brief intervention services around these individualized counseling sessions using MI, but you should also be inclusive of case management services for even at-risk youth, because we all know that they would benefit from these. So as you identify some of these health, maybe, and social needs that lend themselves to the risk issues, it's important to also, in addition to the MI sessions or brief sessions, offer case management services around maybe some areas of support or some mental health or medical health kind of risk needs that you see come up that would be good for you to offer services. So where do you obtain information around these larger needs? It might be some juvenile justice issues and they got into trouble. They don't meet criteria for having a substance use disorder, but they still might need some help with community service or whatever it might be that your case management services would lend themselves well to. So you get this during your ASAM assessment, right? So assessment informs case management, and a critical piece of case management is planning, right, and a function of case management. And so as you are identifying their risk indicators to talk about them during the intervention sessions, it is also critical that you develop a plan of action around what their case management needs would be, right? And really identifying their needs or their skill deficits, as well as any support or strength areas that need to be capitalized in on. Typically it's the family or it's the school or it's implement, the legal issues or whatever it might be. The needs might be the deficits around self-efficacy or confidence, or maybe it's self-esteem, or maybe it's anger and anger management, these outside support groups that might be needed for youth who are at risk. So this will be individualized and this will be different for everyone, but it's important to recognize that case management is not only about needs, but it's also about honing in on their support and their resources, particularly around the recovery environment and maybe their emotional and behavioral environment. Do they have counselors at school, or do they have maybe it's learning disabilities, whatever it might be, to really hone in on their need. A best practice for case management, and one of the other practices, is coordinating, right, in a way that's active, not passive referrals, but really engaging in active kind of warm handoff, using motivational interviewing, engaging on service teams, coordinating with schools or with legal systems actively, with justice systems, social welfare systems, right, to really hone in on risk factor and protective factor services that might be needed. And so the bottom part really exemplifies, these bottom blue bubbles on the slide exemplify the functions of case management. So besides planning, like I talked about earlier, it's linkages, right? It's being a support or offering maybe coordinating support groups. It's being an advocate, right, for maybe immigration issues, or maybe it's school issues, or maybe it's an advocate with their probation officer, or it's monitoring. Did they follow through with the case management services? Did they follow through with that? So it's following up, it's checking in. And here's a list of kind of elements around the risks and protective factors that should be addressed within a case management setting. It's positive health, right? Physical development and regulation, healthy emotional development, and really honing in on management skills, like maybe it's self-esteem and anger, so maybe they need support groups. As they're getting a risk reduction intervention, they might benefit from anger management classes, or they might benefit from a class around self-esteem. That's not treatment for their drug use, right? That's different. They might benefit from, they might have LGBT issues or identity issues, and they're at risk. So they might benefit from some emotional development through a list of support groups. So it might be useful for you to have those, if you don't have them within your system, to have outside connections or resources where you can, link them to. Cognitive skills around problem solving, this whole notion of supportive social relations with family, and what maybe case management. During a brief risk reduction intervention, there's no family services where the family's given. However, it might be an area where it's case management, and maybe parenting classes are offered, or some type of support group there. Recognizing the need for presence of mentors or support if youth are involved in gangs or these types of more riskier environments. It might be useful to look into organizations and agencies that provide mentoring, like after-school programs. I know in LA County they have different kinds of programs around mentoring and support that really develop skills like after-school YMCA programs and recreational programs, and really providing those types of resources is critical. And then opportunities to engage in the school or community, like dealing with their legal issues, like the community service work that usually gets like not addressed, or youth don't know how to do it, so maybe coming alongside them and doing that with them. And then if there is any safety issues, you know, physical or psychologically, if there is gangs or if there is sort of some issues that were identified early on, and getting involved in the social welfare system, I mean, that would be a case management kind of area as well. Housing, these types of issues. Okay, so that's at risk. We are now, I should open it up for questions at this point for anything at risk before we move into how we address medical necessity, or how we kind of engage in effectively to begin to start thinking about addressing youth who meet medical necessity, and what are those kind of next steps from a big picture. Are there any questions on what I just covered? No. We can wait till the end. I just wanted to check in.
Nobody has any questions right now in the room.
Okay, we'll wait till the end. So how do we effectively address youth who meet medical necessity for a clinical substance use disorder? This is moving away from risk, more towards now they meet medical necessity for having a disorder that requires clinical substance use disorder treatment services. So if you look at our specialty treatment system pre-ODS waiver, right, pre-system transformation, you see these boxes, and they're all sort of isolated. And these are these isolated agencies that are in the community that we still have and that are still largely operated in isolation. But the goal of the waiver is really to do ASAM assessment that really dictates or really allows the system to identify service need, right, based on, you know, intensity, based on duration, right? The ASAM assessment around those dimensions are really designed to help place youth in a system of care or level of care that is responsive to their needs in terms of intensity. Do they need more intense clinical services? In terms of maybe do they need lengthier services, right? We didn't have that in the past. We had where youth show up, you know, probably geographically, they just saw, they were, you know, they've opened up their phone book or they asked somebody and they found a treatment program, and it might have been a residential, it might have been an outpatient, right? Or, you know, there's been other ways in which residential versus outpatient were dictated, right, based on different clinical areas of judgment, based on maybe indicators that were used in a treatment system, but it was very fragmented, and it was not systematic, right? So substance use problem identification was not based on any clinical standards. There was no medical necessity criteria used, but rather maybe intuition or these other kind of areas within an agency, or research-based tools. If you've used the Addiction Severity Index, that's a research-based tool really that just allows us to understand how people are doing around dimensions. It has nothing to do with level of care need around severity. And so treatment level of care and planning was not really based on clinical need or quality standards, but rather, you know, this notion of cost around, you know, the short-lived treatment services, of what's covered under, let's say, the block grant, or what's covered under the prior Medi-Cal system, which was short-lived. So all to say, it was very unresponsive and fragmented. And so now as we shift to the waiver, it allows our system of care to really be a more responsive system, where we are now taking into consideration clinical indicators from an assessment tool, the ASAM, that was developed to be used clinically, not for research purposes or not for like cost-saving money purposes, but really trying to parallel the needs of the person with the intensity and length of care that they should receive. So now it kind of looks like a system of care that should follow along a continuum where, based on medical necessity, they should be moved up and down levels of care. They might start somewhere because they meet medical necessity and have more severe needs, but upon reassessment after maybe that level of care, they might still meet medical necessity, but for more lower intensity level of care. So moving somebody, let's say, from residential to 3.1 to a 1.0. And then after that, under the ODS waiver, it says they would need aftercare, right? They would need recovery support services. And I believe the services are covered under the waiver for up to 6 months upon medical necessity. So now we have a very transformed system of care. This notion of aftercare wasn't, back in our previous model, and you might know this from just practice, aftercare was just kind of an afterthought, and it was like, well, we want to refer you. It was like a referral that was given that you should, as you're transitioning out of our structured program into the community, you should really plug into support groups to help sustain yourself. And it wasn't, systematic. It was just kind of given at a discharge moment. But now, through this reorganized system of care, aftercare is an essential part of services, right, that should be introduced early on to youth and clients during assessment, saying, well, this assessment, if they meet medical criteria for a substance use disorder, they should be educated around, intensity and the need for intensity around and duration based on their factors that fall along those dimensions and the importance of aftercare as they transition out. And so I do think because of this, it's critical that we educate youth during the assessment process around this versus say, well, here's, you now have a need for services. What are those services? They now have a menu of options, quote unquote, if you will. But sometimes we also need to recognize that there might be issues where youth, the ASAM might say, well, they need residential, but youth might be like, I'm not going to residential, right? And so being a flexible system, I think, is important as well, and really meeting the needs as well as the client and their families, where should they not be receptive to residential, maybe placing them in a lower level of care, like an intensive outpatient, or if that's not available in the system, maybe an outpatient service, but you increase the intensity of services, right? So you are going to have them come more times or more frequently than a general client who meets 1.0. So really thinking about these nuances, I think, is something that we are pushed to do as a system with these new services and system guidelines that should be thought through as we begin to deliver SUD services for youth. We can cover more about that later because it gets a little kind of complicated, but moving to what's in clinical services. So once they get placed into an appropriate level of care that meets their needs as well as adheres to what was recommended clinically from the tool, what is in the box of treatment, if you will, and what are the clinical approaches, what kinds of therapeutic approaches should we be using and mindful? Well, there's a lot of evidence-based treatments that have been shown to be effective for addressing substance use disorders with youth. And if you visit SAMHSA's registry on the left-hand side, there's a small box there. It's called NREP, and it's a national registry. Many of you might be familiar with a reservoir of programs and practices that have been identified to be evidence-based. What does that mean? It means they've been supported by science and research and practice under research settings to be effective at bringing about improvement with youth in substance use disorder programs. So as you see on the left-hand side, there's MI plus CBT, cognitive behavioral treatments. They're seeking safety, and dialectical or DBT for those youth who have trauma. There's also treatment programs or treatment services and clinical models that are available and been adapted for youth in justice systems, working with correctional or clients or youth in diversion or in injustice. And then in the bottom, there's a whole slew of family-based models that have been shown to be effective. The two most dominant ones are family therapy, as well as multidimensional family therapy. And then there's some others, right? There's anger management that's embedded within CBT. There's this whole area around mindfulness and the effectiveness of mindfulness, but we know mindfulness is an aspect within CBT as well. Trauma-informed care and what that looks like, and then MAT, or medication-assisted treatment. So I'm going to cover a little bit of MAT and where the research is at with that, and then I'm also going to cover, based on all of this, though, which ones should we be using? Well, it's going to depend on your clients, of course, but what the research has shown based on meta-analysis, if you look on the right-hand side, that Tanner and Smith have done with Lipsy, they've looked at the effectiveness of treatment for substance use. That includes use with co-occurring issues like trauma and justice issues, right? And they've done a systematic review. And the ones that have come out in terms of being effective or better predictors of outcomes are these in the blue box. Well, what the study has said is that any treatment is better than nothing, right? So ensuring that youth get something to address, you know, their substance use issues is better than not giving them anything at all, as well as then identifying which models, if you will, are more fruitful than others. MET has come out on top, and we just covered MET, right? We just covered motivational enhancement therapy that uses MI. And it shouldn't surprise any of us that it came out on top, because we are dealing with adolescents who have developmental issues that just cause issues for our system, right? They resist, they don't want to engage, they don't want to be told what to do, they want to be treated, you know, like autonomously, right? So MET and showing empathy and all of those skills we just covered are very effective with youth in risk settings and in treatment settings. So MET is key, but we've also found that using MET with CBT in combination, so cognitive behavioral therapies, right, really honing in on addressing some of the cognitive and behavioral and emotional deficits, right, that need skills, right, is also critical in combination with MI, as well as family-based models, right? The inclusion of family is also a critical component of effective outcomes with youth. And medication combined with behavioral, either CBT or MET, is critical, not just medication alone with youth. And then aftercare. And the importance of aftercare has really been shown to be critical for, aftercare that is meaningful and developmentally appropriate, right? So we'll cover that in these next couple of slides. Why these models, you might be thinking? Well, recall the pathways to adolescent substance use disorders, right? What are the predictive risk factors? And it's all about family, right? Family, 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 as well as these issues around neighborhood and school and peers, right? And developing, these all impact individual factors that need to be worked out, right? What are the individual factors? Well, it's the emotions, it's the cognitions, and it's the behaviors, right? So CBT is really effective with honing in on the skills that need to be developed to address these pressures, like problem solving, like controlling their mood and emotions, like identifying cognitive distortions that might not, like these misperceptions, right? So CBT is critical given this. And then family, if we don't include family in our service models, we are doing ourselves a disservice, and we are doing youth a disservice, because we can't isolate the individual factors outside of a larger environment that they are going to go into and be part of outside of our system. So family, conflict and dysfunction and lack of support are the major predictors of poor outcomes among substance-using youth. If you look at the slide on the right-hand side, it's statistics and it's data from the meta-analysis that has looked at the predictors of substance use outcomes, right, of relapse issues, of continued use, if you will. And the three biggest predictors of poor outcomes is family issues, continuing to have family conflict, continuing to have like issues of family cohesion or not being togetherness, right, and a limited or lack of social support. So again, this notion of redefining family into this area about just support system and really recognizing the importance of really helping youth engage in pro-social supportive activities in the community and in their environment that are going to help against these issues of what? Neighborhood, school, and peers, right? So really recognizing that this support system or engaging youth in social support activities like wellness and recreation and pro-social behaviors within a context of these social activities is critical, because we know from research that the single best predictor of behavior is behavior, right? So ensuring that they have support to engage in pro-social behaviors is key. So the left-hand side just shows the issues that are found in the research that lend themselves to be predictors of poor outcomes. So with conflict and cohesion, it's parental substance use, it's poor parental monitoring, it's family conflict, it's poor communication, right, and it's having just family kind of lifestyle issues of SES factors, poverty. The family models, like multidimensional model and the family-based treatment model, get at poor communication, and they get at this issue of conflict and how to resolve problems through problem solving. So they hone in on these critical areas that have been shown to be issues with youth and youth outcomes, right? We do know that parental engagement is an issue, right? That's in any system. That's even in the school system. Getting parents to go, beyond the parent-teacher conference, have them actively participate in things like events and the parent-teacher, the PTO meetings, and all of these other kinds of things. They're not involved, right? So we know that parental engagement is an issue across the board. And there's a lot of barriers, in particular within the systems of substance use and mental health, right? There's parental frustration. There might be parental dysfunction on their own with use and mental health issues. Access, they might have issues with, they have other kids, their schedule and time they might work. And then cultural stigmas, right? Really not really understanding substance use and viewing it as this shameful, stigmatizing issue that they don't want in their family or part of their kid having it, so they're embarrassed and they don't want to be part of it. And then just lack of knowledge, right? Just not really understanding the importance of being involved in the therapeutic process, right? So them thinking that the treatment system is supposed to just fix their kids, right? This norm around fix them, that it's a quick fix. So again, remember I talked about assessment, really bringing them into this environment and really educating them about the process and the importance of them being involved in overseeing maybe the case management or the support, and having them recognize that the family dysfunction and the lack of support are the key factors of why their kids are continuing to use drugs, right, and alcohol. So getting them to realize that is, I think, critical. Also getting them to realize that research has shown that the inclusion of a support network or a family is a major engagement tool, right? It helps youth transition into a system and stay on track, where youth are helping them with their homework or helping them with, ensuring that they get the needs that they need to get at school systems or whatever it might be. It's the same idea. It's getting parents to be mindful of youth are going to be getting homework based on their cognitive behavioral, treatments. They're going to be getting exercises around problem solving, or they need to be involved in that as well. And so we do know from research that youth come into treatment from the justice system and getting in trouble. And I do think if you see the red bar, having parents recognize that they get referred on their own, but they need to despite being referred on their own, they need to come with their children, given the major issues associated with not engaging. And parents need to be told up front, your son or daughter is not going to engage in this program, and we need your help. We need your support. So getting them to involve is critical. To be involved and understand their role in their kids' involvement is critical. Why else those strategies? So I talked about parents. Why else? Why MI, why CBT, and why medication and aftercare? Well, remember the developing brain, right? And there are major determinants of recovery that are targeted by the practices of MI and CBT and medication and aftercare. If you look at the slide to the left, treatment outcome studies tell us that most young people, more than about half, continue to use during treatment. They don't stop, right? Just because they're in treatment doesn't necessarily mean they're going to stop using, right? They're just figuring out ways to lie better or not get caught, right? So that's a major issue. Research also shows us that the majority, more than 50%, relapse. They continue to use after treatment is done, right, within that first initial 3-month window. More than up to almost all of them, 85 to 90% of them, will continue to use and go back into their old kind of behaviors 1 year post-treatment. Less than 10% of young people participate in aftercare after formal treatment ends, right? They're just not engaging in the community support programs like NA or AA that are available. This is an issue. This is a critical issue for our system that we need to be mindful of these statistics, right? We need to share these statistics with our young people and say, you know, and we need to be mindful that our treatment outcomes need to be developed to meet the needs of the youth, right? So MI is critical, right? We need to meet them where they're at. What stage of change are they at? And recognizing that up front, because most of them are continuing to use, right? And thinking that just because they enter into a treatment program, they are going to be in action mode is a belief that we should not be thinking, right? So really honing in on that MI. The following elements, right, in the yellow box are important to address during treatment among youth, right? The emotional, cognitive, behavioral issues that are occurring developmentally, the motivation and the readiness, and the stressors and the continued stressors, right? And the environment, or the lack of support. If you look on the right-hand side with the brain, these are critical areas that the programs or the practices allow us to address, right? Inhibitory control, right? This ability to self-control or self-manage their behaviors is critical, behavioral skills. Motivation and drive is another area that's being impaired by substance use, right? Readiness, critical area to hone in on. Emotions and the amygdala and the mood regulation is another critical area under development being impaired by drugs and alcohol. So coping and coping skills. Learning and memory, right? The critical nature around cognitive skills, around problem solving, right? Around decision making is critical, and learning how to control, inhibitory control would be maybe learning how to control anger, right, and behavioral skills around that, or learning how to do new behaviors that would inhibit, that would help them kind of work towards dealing with impulses. And then craving in the red, right? Craving is a new phenomena that got added to the DSM-5 that we talked about before, where legal got removed and craving got added. And so this whole notion of craving and how we need to be really mindful around what craving looks like and how there might be some coping skills related to craving, or the need for activities around how to address craving or identify craving, and then use cognitive and behavioral and coping skills to help with that. Or be open to the use of medication, right? So medication-assisted treatments that have been identified to be effective for youth with opioid and alcohol use disorders, or specifically useful to address craving, right? To help them eliminate or reduce the craving that is becoming very strong. Meanwhile, as they work on developing skills around behavioral self-management and maybe coping, cognitive and behavioral through CBT or MI. So there might be youth who would benefit from medication should craving be an issue during assessment and during their planning. That would be something to consider. We'll talk about that in a couple of slides because I do have some more information on that. So it's all about, based on this information, you should be thinking like, well, these treatment models make sense because it's all about dealing with their motivation, right, and skills and support. So what MET and MI allow us to do as providers is it allows us to respect the autonomy and stages of change and resistance, and allows us to evoke intrinsic desire to change, right, with youth as they're in our program. CBT allows us to hone in on the cognitive, behavior, and emotional skills that are being impaired, right? Teaching them cognitive skills and impulsive control, maybe judgment and thinking, problem-solving skills, coping skills for stressors and craving, and then family support. The support notion teaches us skills in communication and conflict resolution. So all to say that all of these evidence-based practices should have the goal of instilling skills and encouraging change and readiness and working on that motivation and that drive to really help the youth self-regulate and self-manage with supportive resources. The effective clinical therapeutic strategies then we would end with is MI and CBT, and these are actually two strategies that have been identified in the waiver, ODS DMC waiver, as effective strategies to work with youth. So they are those, they've been described. Some other ones that have been selected depends on the practice of the providers that providers will use will be like relapse prevention. This is a different kind of model, but it really uses CBT and MI kind of in a combined way. So, if your system has used relapse prevention, you know that MI and CBT are kind of combined within this structure of RP. Also, trauma-informed treatment, you might lean more toward DBT or trauma-informed depending on your use that you might work with. So you might adopt MI and CBT, but also include trauma-informed kind of practices depending on the individual and the nature of your system. And then psychoeducation is also a critical element in really providing education around, this nuances around the brain and nuances around substance use disorders in a way that is personal, in a way that is meaningful. Just like we talked about during the risk reduction intervention, I think the psychoeducation should be shifted around the individual needs of youth and really providing them with education around that, but also being mindful of the importance of support groups, right? We do know that youth are coming with issues of identity issues, maybe gender issues, maybe LGBT issues, maybe anger issues, maybe gang involvement issues, right? And so number 5 and number 6 might be, you might lean towards them depending on the nature of the youth, and the psychoeducation groups, right, rather than do CBT or MI in group settings, really shifting the practice of doing CBT and MI in an individual session that the waiver allows for, really meeting the nuances of the individual needs, and using the group sessions to provide psychoeducation around, let's say, anger, right, where youth might be welcome to do that should they need it, or trauma, and a support group around trauma, or a support group around LGBT issues, right? And so really tailoring your system to meet the needs of youth developmentally versus just do group and they all get group that talks about CBT when they're actually different and they might have different needs around different skill development. So something to consider. So medication-assisted treatment as an EBP, research that been published in JAMA, the article on the right, shows trends in the use of buprenorphine and naltrexone for opioid and alcohol use disorders among adolescents and young adults. They've looked at a decade or so more of work on the utility and the efficacy of these medication-assisted treatments for youth with opioid and alcohol issues, and they found them to be effective treatment agents for youth that have issues of craving in particular. So that's why on the left-hand side, as you're doing your assessments and youth, should they have alcohol or opioid use disorders, and really paying attention to craving, really paying attention to if they've been in treatment before and how responsive they were with treatment, were they in residential or outpatient treatment programs before, and what did their outcomes look like? Maybe they weren't responsive. Using your clinical judgment around they might need more assistance, and medication assisted treatment might be something that is offered as a viable option to families and youth that it might work or be beneficial. So research has shown that issues with overdose is another indicator in your ASAM tool that you want to look at, or issues with craving should be indicators of potential utility of medication-assisted treatment. Naltrexone has been shown to blunt cravings and reduce heavy drinking among youth 15 to 19, and youth with opioid use disorders given buprenorphine or had favorable outcomes with withdrawal and craving. So I wanted to put it on your radar to increase your kind of preparedness around that, and think about it as a viable option within a new transformed system of care, and working with other maybe systems or providers or within the county that have that, or maybe with addiction psychiatrists or addiction doctors that might be within the local health centers within Shasta County might be an option for you to consider should you have youth that meet criteria that would make this a viable option. Case management is also critical, right? We talked about it with risk reduction. It is also critical with youth with disorders, right? Really honing in on their health service needs and their social service needs, right? Around education, around assistance with maybe skills around career and options around that. Importance of case management during treatment is critical. Why? Research has shown that in order for youth to be successful at engaging and adhering to treatment models, incorporating case management can be beneficial to addressing barriers of engagement in, learning CBT and learning some of the skill sets around you're giving in the treatment program. Case management services can help offset some of that, right? So if they're not really engaging in treatment, but if you're giving them critical, source resources and support within an area that also meets their needs, it's going to continue to help them plug in a way that might allow them more receptivity towards treatment and treatment services. Again, remember we're dealing with youth who really don't see substance use being problems. You're going to meet those same issues with youth who meet disorder criteria. In the work that I've done with youth that I exposed you to early on, I did focus groups and I did a lot of interviews with youth in treatment with clinical substance use issues, and they viewed substance use still as a behavior that they can change that required personal control. They viewed recovery as lifestyle change, right? So case management is helping them change their life, right? Engaging in educational and mental health and medical support systems, right? And services that are going to be critical for them in ensuring that they're on a trajectory of behavior change. So being mindful of that versus putting all your focus on the treatment and like they need to be learning CBT and they need to be doing CBT, I think we should allow ourselves some room to breathe, and we should also be actively engaging and really honing in on case management sessions and services as ultimately helping meet the overall goals of our youth and better outcomes. So then it doesn't stop after they've received clinical services within a level of care, right? Outpatient, residential. Aftercare is essential. It's an essential critical practice. NIDA, the National Institute of Drug Abuse, recommends it as an effective practice of treatment programs, right? Not ending with just treatment, but really ensuring that they are being plugged into after they've received clinical services, and to ensure that what they learned around skill sets, around how to manage their mood, how to manage their anger, how to problem solve, that they're being followed up on to ensure that those skills that are being practiced and they're being checked in on. So aftercare is a check-in process, right? It's not continued clinical services, but it's offered in a way that is going to ensure that what they learned in treatment, they're continuing to do. And if they're not doing it, how can you engage in helping address those issues, right? Maybe they need another resource. Maybe they need to be they need to talk about that skill in a different way. So it's continuing to talk about and follow up on what they learned in treatment. And so this is critical, right? And so what the waiver has done is it's expanded beyond the usual aftercare model, right? The usual aftercare model in our field has been NA or AA. It's been these support groups that don't follow up on the skills that they've learned in treatment. What they do is they offer a support environment to talk about, you know, how long they've been sober. And they say, and they reinforce this notion that they're an addict and they're in recovery and they've been sober for 1 year, 5 years, 10 years. That's an effective, this is NA and AA are effective. They've been shown to be effective, but they've been shown to be effective with adults who have chronic disease and illness, right? Who have relapsed several times, who have been in and out of the system, who know that they need to never use alcohol and drugs again because it will, you know, it's part of their biochemical makeup that they need to stay away from. Young people do not follow those parameters, right? They don't have enough time with using alcohol and drugs. They haven't seen the consequences. They haven't been probably in and out of the system with relapse. So NA or AA isn't a viable model. Research has shown that youth tend to reject NA or AA. They don't really see the need for continued support because they're done, right? They've got their treatment done, and they should be good, right? What they need to work on is lifestyle change and really honing in on the skills. And research has shown that alternative models are needed. So the waiver includes these alternative models that have been shown by research to be effective. This is continued counseling, right? These groups are individual or group services where they still need help maybe working on the skills that have been talked about in treatment, right? It's recovery monitoring, it's coaching, it's following up either telephonically or in person to check in and monitor how they're using the skills they've developed in treatment, right? Monitor are they still on their treatment goals, right? Are they still engaging in problem solving? Are they still using critical elements of coping that were learned while in treatment? It's assistance to peer-to-peer services or maybe relapse prevention, right? So it's engaging them in maybe alumni groups, right? It's having them come back into alumni groups in a more structured and formal way. Family support is another critical element of aftercare, and so it's still including the family as part of the monitoring and how youth are doing post-structure to unstructure. It's still offering case management, right? It's ensuring that youth are engaging in their mental health, their legal, their housing, their school, service coordination. How are they doing with these areas of need? And then it's support groups. It's still offering youth the option of going to community NA or AA. These are more helpful in the work I've done with youth, with the older age youth, like more of the 18 to 20-year-olds, you know, under EPSDP waiver, the 12 to 20-year-olds are eligible for services. So if you do have 18 to 20-year-olds, there are young adult NA or AA groups that have been formed. They're online, or they might be in your community. So I encourage you, you might already have them on your list of resources, or it might be plugging them into churches or faith-based kinds of communities, right? And linkages to other support groups in the community around things like LGBT issues or anger issues, or, right, it's really finding groups that offer support to meet their needs. It's not, it might not be the traditional NA or AA that is effective with adults, so we need to be mindful of the developmental needs around support groups with youth. It might be eating groups for youth, should that be an issue. It might be, you know, different groups around maybe gang involved, you know, and having them include themselves in a community-based organization that works on mentoring and issues as such, right? So it's really honing in on, again, all of their issues that were identified in treatment and really how plugging them into these support groups that are needed in the community beyond the traditional NA or AA has been shown to be effective. So here are some resources. I talked about these evidence-based treatment programs. They're available on SAMHSA's website. So tip 32 has treatment for adolescents with substance use disorders. Tip 27 is on case management. I talked about case management services and the role of case management. This whole notion of youth with co-occurring disorders, we've mentioned trauma, and we mentioned DBT a little bit, but maybe getting more familiar with those is tip 42. And then the risk reduction intervention, so TAPS 33 provides you information around brief interventions and around the sessions and how they should be, you know, 30, you know, brief sessions over a period of time. So it has a resource there on it calls it ESPERT, but it really hones in on the early intervention or the brief intervention. So I just wanted to alert you to some of those resources. I will be sending these slides as well as last webinar 1 slides to Amber, who will send them out to you all so you can have them. Here's my email. I will be working with your county to develop more tailored trainings around some of these areas around, like, you know, family-based treatment and what that is, and get more involved in that, get more involved in what CBT might look like from a developmental perspective and the practice of that, and also the practice of risk reduction. So stay tuned for those. I just wanted to provide you with kind of big picture developmental framework around what are viable and effective ways from a therapeutic stance to address risk and clinical disorders among youth. So with that, I'm going to now open it up for questions or comments.
Wow. Does anybody have any questions? So, Rachel, this is Diana. I did show up about an hour ago.
Hi, Diana.
Hi. I had to do the other part of my job and go to the Board of Supervisors this morning. I'm sorry.
Of course. Yeah.
So, just to make sure that this group knows, I've talked with